Dr. Sigalove in Scottsdale. So a lot of people ask about my subfascial technique, the Sigalift, and is this associated with a higher capsular contracture rate? The answer is absolutely not. We have data to prove it. We're publishing this. The bottom line is this: we know now the etiology of capsular contracture most likely is bacteria entering the pocket, colonizing the surface of the implant, forming a biofilm that the body then recognizes and forms an inflammatory response against, which is the beginning of the encapsulation process and scarring formation. So the point that I'm trying to make is that above the muscle surgery does not have a higher incidence of capsular contracture as we used to think. In other words, capsular contracture is not related to the position of the implant, whether it's above or below the muscle. It's related strictly to the presence of bacteria in the pocket. So by using the 14 points, using meticulous antimicrobial techniques, using betadine in the irrigation, using hypochlorous acid, glove changes, no-touch technique, Keller funnels, nipple shields, all these things minimize bacteria. By minimizing bacteria, we're minimizing capsular contracture. So your surgeon is actually incorrect when he tells you that implants above the muscle have a higher capsular contracture rate. That was true in the 1980s and 1990s when horrible technique was used with bad saline implants. The subglandular implants, saline, had a much higher capsular contracture rate than the submuscular salines did. However, when they looked at silicone implants back in the 80s and 90s, the difference was not so profound. So in my practice, subfascial breast augmentation is prevalent. I probably perform it in 85 to 90% of the primary augmentations as well as revisions that I do, and I feel 100% comfortable that I am not going to have an increased risk of capsular contracture. We have a lot of data that proves this. It's been published, and we're continuing to publish our results on a regular basis.